Thank you, madam, for a nice presentation. I would request Dr. Purvi now to tell us how we should take care of our BLEB that is just in bed. Because we know that all the story of the struggle starts after we do the surgery.
Thank you, Dr. Dipanjan, for including me in this IC. So now that the surgery is over, the most important thing is to take care and nurture your BLEB. So what will you do in the post-operative period? The most important thing is the vigilance and assessment and management of the post-operative care. The first thing that you have to keep in mind is to explain to your patients that all pre-operative IOP lowering medications should be discontinued, because sometimes we just focus on the post-op meds and forget to instruct to the patient to stop all those pre-op anti-glaucoma drugs that they have been using for months and years, and especially the acetazolamide. So that should be stopped because it may inadvertently lead to hypotony and unwanted complications. The type of steroid that you use should be the drug route and duration. It should depend on the degree of scarring, expected level of BLEB inflammation, and the presence of risk factors for failure that are there in the patient. And the cycloplegic depending on what is the depth of the AC and what is the inflammation that is happening in the eye. But the most important challenge is recognizing when you need to intervene, what is the type of intervention that you would be required to do, and intervening at the right time. So what are the possible complications and scenarios that can happen in the post-operative period which can affect your BLEB? So one is related to the hypotony with a flat or a deep AC, and second scenario is a case of elevated intraocular pressure with a flat or a deep AC. So let us see briefly these different types of scenarios. The most common is a low intraocular pressure with a shallow or flat AC, and your BLEB is not yet formed and it is totally flat BLEB. So this could be a case of wound leak or a delayed BLEB leak. Wound leak is very easy to identify using a Seidl's test. You can see the trickle of aqueous fluorescent stained aqueous coming out. So if it's a very small leak likely to heal by conservative measures, you can just patch tightly cycloplegics to keep the AC as formed as possible, reduce the frequency of steroids to stimulate healing, and a bandage contact lens can be tried. But if you apparently feel that the wound is large, the gaping is very large, not likely to heal conservatively, or your conservative management is not working, then of course you have to undertake for a resuturing. If again the conjunctiva is very friable or your sutures are not staying into place, then you can use other measures like a conjunctival sliding, advancement, or a free graft. If the conjunctiva again not staying in place, you can even try an AMG, and sometimes people have also tried using fibrin glue when the suturing is very difficult or the sutures are just giving away repeatedly. And all these measures can also be tried when it's a delayed case of a BLEB leak or a BLEB oozing. The second scenario could be low intraocular pressure with a shallow or flat AC and a flat BLEB, which happens because of overfiltration. So again here the conservative measurement management would be the same, that is patch, reduce the steroids, cycloplegics, ask the patient to avoid any kind of strenuous procedures which can actually increase the amount of filtration, and BCL if possible and required. You can continue the management conservatively unless you see the typical corneal hypotonous folds that are there. It's a grade 3 shallow AC having a lenticular corneal touch, and the vision is compromised because of a hypotonous maculopathy. So the first thing here that you need to do is reform the AC. You can do it with air, fluid, or a viscoelastic substance. But remember that this might just have a transient effect, and you might even have to reform the AC repeatedly. If you feel that this is not working, the AC is still not staying well in depth, then you will have to undertake for a revision. You have to open the conjunctiva and see the scleral flap and see what is the status of the suturing there. You might have to tighten the sutures which are there, maybe take additional sutures, or if there is a scleral tear, dehiscence, a scleral hole, then you might even have to take a scleral patch graft to close that area of excessive filtration. Overfiltration can also be there with low hypotony, but a deep AC and a large BLEB. Again, this has a benign course. Sometimes it just heals down with the BLEB remodeling that happens. You can take BLEB compression sutures later on if you feel the need to do so. They can be horizontal or vertical. Autologous blood can be injected in the BLEB to again stimulate the healing and stimulate some amount of scarring. And if none of this work, then you might actually again have to take the patient for resuturing, excision of some part of an unfunctional BLEB, or actually revise the entire surgery. Choroidal effusions can present with low intraocular pressure, shallow or a flat AC, and a flat BLEB. These are again very benign, usually resolve spontaneously with atropine and systemic steroids. We have also used difluprednate in these cases because on one hand they help to control the effusion component, and they are also said to increase the intraocular pressure. So it will actually help to counteract the hypotony. So difluprednate does help in these cases. Drainage is rarely required with the choroidals. The second scenario is the elevated intraocular pressure. With a flat AC, it could be malignant glaucoma, pupillary block if your iridectomy is not adequate, or a delayed suprachoroidal hemorrhage. But because of constraints of time, I would just focus on the other aspect which is more critical and important, that is elevated intraocular pressure with a deep anterior chamber, which are signs of BLEB failure. So what are the signs you need to actually watch for? A changing vascularity, when there will be increased local conjunctival hyperemia, excessive vascularization in the form of corkscrew vessels. The BLEB, instead of becoming diffuse, it is localized. Instead of translucent, it is opaque. And instead of moderate elevation, it could be either dome shaped or it could be just shallow or flat. And there would be a trend of increasing intraocular pressure during the first month. So all these are signs that probably that BLEB is going into a stage of failure. So the first and foremost thing that you need to do for failing BLEBs is do a gonioscopy and check for the ostium, whether it is an internal blockage that is there or it is an external blockage. Sometimes that can be evident. You can see on the slit lamp there is a peaking of the pupil. You can see that the pupil is actually, the iris is drawn towards the ostium. So here, if it's early on, you can even try pilocarpine, which can allow the meiosis to happen, and if it's fresh and not yet adherent, the iris may just come back from the ostium. It's a minimal in amount. But sometimes you can see it's actually a synechia. There can be iris tags if it's in improperly done iridectomy, or the iris is pulled back and then it is just stuck there and it doesn't respond to meiotics. So in all these cases, then you will have to intervene surgically through a small side port. You can just pass a spatula or an iris repositor and release the iris from there. But if the sclerostomy is open in your gonioscopy, then probably it's inflammation or it is actually fibrosis that is causing the underfiltration. So inflammation, of course, it can be, it will respond to intensive topical steroids continued for a long time. For the tight scleral flap, we can try digital massage, that was already discussed, but it's not so easy and not usually so effective, but it can be tried, and once you find it is effective, it can be explained to the patients also. But if this is not working, either with digital massage in the OPD, the flap is not opened up and the BLEB is not forming, or even after the patient is doing it at home, it is not working, then as Dr. Mayuri Madam just said, you can try any of these, remove a releasable, do a laser suturolysis, loosen your adjustable sutures, but always remember that if you do it, it has to be in a stepwise fashion. All releasables and all adjustables should not be treated and manipulated at the same time, and timing is very critical because too early on might lead to hypotony, delayed might not be effective, and it also depends on whether you have used an antimetabolite or not. Again, if this is also not responding, then of course you will have to restart your anti-glaucoma drugs and resort to either needling. Again, if needling fails, then of course revision or a resurgery can be considered. But do remember that the more delay you have in your intervention and whatever additional manipulations you do, everything increases the risk of BLEB failure in your patient. So to conclude, you have to keep in mind the 5 C's, a careful postoperative assessment and vigilance, keeping a check in the intraocular pressure, AC depth and all the BLEB characteristics and every single visit, careful assessment for the cause of failures and complications. You can try conservative measurements initially, but when there is an urgency or when the conservative measures fails, do consider an early surgical intervention. Thank you.
That was an excellent and very comprehensive talk from Dr. Purvi. As we know that the BLEB, if we can make the BLEB survive for at least first 12 to 18 months, there is a first struggle. then we can ensure that it is going to have a favorable filtration for at least next 5 to 6 years. So our next speaker would be Secretary Glaucoma Society of India, Dr. Chandrima Paul, who will take us on through the use of Ologen as an augmentation in trabeculectomy. Sorry? Yeah, it is. Right now it is not available, but it has shown enough evidence that it may be as good as mitomycin C. As because there is in trabeculectomy we need a perfect balance between a safety and efficacy. Sometimes use of mitomycin C can be devastating if not used properly, but Ologen gives us that platform where we can use adjuvant in glaucoma surgery, keeping safety in mind, and also it can be maximally efficacious. In between, if anybody has any question, one question we can take, but we have a lot of time to take questions at the end of the procedure, end of our course, sorry. Yes. Yeah, of course, Dr. Muri madam will tell.
It is not essential to remove delisable in all the patients. If you have achieved your target pressure, it has been maintained, you may not remove it. After 3 months, if it is not needed, then you can trim it at the edge of the wound. So there is no loop left outside, which can be a potential